YouTube पे लाइव है।
हाँ जी सर, बस ज्वाइन की है सर, मीटिंग करी।
ठीक है, बस उन्होंने लादा ना कि तुसी मूरे बैठोगे, आई विल सिट।
Dr. Randava, good morning.
Hello, sir. Dr. Rabat.
Good morning.
Good
How are
morning.
you?
Oh, tic tac.
Absolutely. Rajesh sir, good morning. Good morning
Good
to all.
morning.
All set?
All set, and you can see already before time
Yes, sir.
our
Great.
students have lined up.
Wonderful, wonderful. Wonderful scene, sir.
Good.
Randava sir, good morning.
Morning, sir. Morning.
Or Kamal.
Good morning, sir.
Hello.
Hello.
Kamal.
Hello.
Yeah.
Sir,
Good morning, Kamal. Good morning, Peter.
Good morning. All set?
Dr. Manmeet, good
Am
morning.
I audible, sir?
Yeah, absolutely.
Yes. Thank you, sir. I think it's clear because my voice would matter a lot to these contestants.
Yeah, of course. That's the most important thing.
So I hope it's clear, loud and clear to everybody.
Has Dr. Manmeet joined in yet? Oh, yes, you are there. Dr. Manmeet, hello. Hello.
Hello,
Dr.
hello.
Nirmal. Hello.
How are you?
Good, good.
कैसे हैं आप?
ठीक है, and we are utilizing your
Nice
services.
endeavor, you know. Middle of.
Yeah.
चलो,
Good
we are
afternoon,
waiting.
everyone.
हाँ जी, good afternoon.
To all the participants, I request that you should check your audio, keep your video on all the time through the quiz. So just check out your connectivity and audio issues right now.
Sanjeev sir, Dr. Subramaniam has joined, so if you want to start, we can start.
Okay, we'll just have to confirm that all the teams are in.
Yes, sir.
So Dr.
Yeah.
Manmeet is checking that. Yeah.
From our end, we are ready.
Okay. Okay.
Team DMC,
Here, ma'am.
yes. Team CMC Ludhiana,
Yes, ma'am. We are here, ma'am.
okay. GMC Patiala, SGRD Amritsar,
Yes, ma'am.
GMC Amritsar. We can't hear you. GMC Amritsar, we can't hear you. Unmute yourself. PGI Chandigarh
Here, ma'am.
and GMC Sector 32 Chandigarh.
Yes, ma'am.
So I think all the teams are here, and Faridkot.
Yes, ma'am. GGS. We are here, ma'am.
Yes. So all the teams are here in attendance.
Did we check GMC Amritsar? Are they on?
Yes, GMC Amritsar.
Okay.
Please be near to your computer so that your audio is clear. Good afternoon, Dr. Sangeeta ma'am and Dr. Sanjeev Singh Rawat sir.
Good afternoon, all stalwarts and great teachers. And God bless these little souls, our students. And all the best to the students.
Dr. Diljit sir, I would request you to start the proceedings because
Okay.
the attendance we have taken up.
Right. Okay. So I think we are all set and ready to start. I hope everyone's connectivity is fine and you are able to hear the voice properly. Even if the visual is not too good, at least the voice should be clear. In case there is any technical issue about the voice, please indicate immediately so that we can take that into consideration, because this is one handicap which always comes in sometimes, and so we should be ready for it. Although I hope that everything will go very smoothly. On behalf of the National Respiratory Chapter of IAP and the Punjab and Chandigarh chapter of the Respiratory Chapter and the Satluj Academy of Pediatrics, I welcome all of you to this quiz program of North Zone, with respect to the World Asthma Day celebrations. Now, this is part of the Presidential Action Plan of the Indian Academy of Pediatrics National Respiratory Chapter, Dr. Subramania. And I'm very happy that the Secretary of the National Chapter, Dr. Rawat, is also with us, along with Dr. Sangeeta is here, and all the other senior persons and dignitaries. Welcome to everyone, and especially to all the students who have very nicely cooperated and have wanted to join this. In fact, initially we thought there would be only 5 teams, but seeing the response now, we are forced to have a preliminary round so that we can choose 4 teams for the final round, which will be held tomorrow. Now, this is, obligatory now, because we cannot possibly have 8 teams for the final round. The aim of this quiz actually are 2. One is to commemorate the World Asthma Day on the 4th of May as part of the program, as I've just said. And the second is to promote learning. Now, that always is one of the important aims of our academy. And this quiz is a very, very interesting and nice way of promoting learning because it's enjoyable. It's entertainment plus learning. It is participative, and there's an element of competition here, which is not really competition in that sense. I mean, nobody is losing, everybody is a winner. And so all of you who are participating, you'll be getting certificates. You're all winners. So don't bother about the results. Don't bother about the scores. Try to learn as much as possible. And even those who are not going to participate and just witnessing, they will also be learning. In fact, we all will be learning. So that is the basic aim of this quiz. Now, there is a certain format which I think you are all already familiar with. This preliminary round has 8 teams. So obviously we will have to go from one team to the other in sequence. And just to eliminate any kind of bias, the teams will be allotted the letters A, B, C, D, E, F on the basis of lots. So as you may be able to see, I've already prepared 8 papers of lots at random, and I'll just mix it up. And as I draw out each one, that particular college will be labeled as A, B, C, D in that order. Is that fine for everyone, all the students? Fair enough?
Yes, sir.
Right. So we will start with team A. The team A will be GMC Patiala. So the scorer, please note this down.
Kamal and
Yeah. Team A is GMC Patiala. Okay. Team B is PGI Chandigarh. So please note your own team number and a team letter, and also the scorer should be very clear that these are the teams which are involved. Team C is GMC Faridkot.
Yes, sir.
GMC Faridkot, Team C. Team D is GMC Chandigarh. Okay, that's D. Team E is DMC Ludhiana. Team E, DMC Ludhiana. Team F, GMC Amritsar. Team F, GMC Amritsar. Team G, CMC Ludhiana. And Team H is SGRD Amritsar. So as we have devised this particular quiz, it is going to be in 2 rounds of 10 questions and 1 minute each. We will go from Team A to Team H, 1 minute each, 10 questions limited to 1 minute. And then we will have a second round in the reverse order, starting from Team H to A. So there will be a total of 20 questions for each team. And you will be given a total of 2 minutes, that means 1 minute each. Why we have broken this is so that you have a little bit of respite, otherwise mental blocks can be there. You can have some little rest in between the first round and the second round. At the end of one round, we will also have a very short 1 or 2 minutes little break from the quiz so that the team H can recover from the trauma of the first round. Okay, so is everyone clear about this? We will learn about the rules very shortly from the quiz conductor, who is Dr. Kamal Singhal. And he is ready, I think, with the scorer. And we need to be very efficient, quick, and alert in this. I hope the sound is fine and clear to everyone. And now I'll hand over to Dr. Kamal to conduct the quiz after giving you again a proper set of rules which we are going to follow. So over to Dr. Kamal.
Thank you so much, sir. I would just like to intervene and request all the teams to write, to name themselves as their teams. Like Chaitanya, you can name it as PGI Chandigarh. That makes it easier on the screen.
Yeah, Team E has already done
Write
it.
your college
DMC.
name and your team name, team A, B, C, D, like DMC has done, team E, DMCH, so that it is easy for Dr. Kamal Singhal to ask questions. Secondly, I would request everybody to be on mute when the questions are being asked. Only Dr. Kamal Singhal and the answering team should be unmuted. Rest of all should be on mute so that there is no disturbance in the audio.
Yes, sir. Can Dr. Subramaniam address for a few seconds?
Oh yes, I didn't know. I didn't know he was on
Yes,
board with
yes.
us. If he's there, it definitely we would like him to speak a few words because this is his show actually.
And
So
Dr.
Dr.
Diljit sir,
Subramaniam,
Dr. Sangeeta is also there, Vice President North Zone.
right.
Ma'am, you are with us.
Thank you very much. In fact, we will have our final round tomorrow, but for this preliminary round, because some of the people may not be participating tomorrow among the teams. So I request Dr. Subramania to please share some thoughts with us. I was not aware that you are logged in with us, so sorry for that. But please, we look forward to your words. Yes.
Sir. Sirji, it is pranam from my side. You don't have to apologize. You are teacher of. Sir, at the outset, let me congratulate the team for organizing the event on the celebrations of World Asthma Day, and hats off to all the people who have coordinated, prepared, and coming to the point of execution. And my dear students who are contesting and participating, all the very best to you. Maybe the best team win, but all of you are winners. And let me also thank and congratulate Dr. Rawat sir for taking such a good initiative on the eve of World Asthma Day and making this a reality. And wishing the teams as well as the organizers all the best. Dr. Daljit Singh sir, warm greetings from Bangalore and from Indian Academy of Pediatric Respiratory Chapters. I represent all members of the chapter, office bearers as well as the executive committee members in wishing the organizers as well as the team a grand success in the quiz. And I recognize the presence of very senior teachers from reputed institutions and apex institutions. Our greetings from the chapter to you as well. And thank you very much and all the best.
Thank you, Dr. Subramania. And I think we need a word from Dr. Rawat also at this stage because he is the brain behind conducting this whole sequence of quizzes, asthma quizzes. Dr. Rawat, please.
Thank you, Dr. Daljit Singh and all the people on the board. I welcome all of you. I welcome all the teams who have been preparing so hard for this World Asthma Day. My best wishes to all of you. May the best team win. But most important is that all of you have studied, all of you have discussed, all of you have participated in discussion on asthma, and may any team win, but you all will be benefited because what is the knowledge you have gained today, it help you in long run. Best wishes to all, and now let us start the quiz.
Thank you. So everyone, please mute yourself.
Dr. Sangeeta ma'am, please
Yes.
give encouragement to the teams.
Thank you very much. Very good afternoon. It was a wonderful, innovative, and interesting way. I congratulate the respiratory chapter and the Punjab state to take this initiative of Dr. Subramaniam and Dr. Rawat, and along with all the teachers, stalwarts, Dr. Daljit Singh, Dr. Harmesh, Dr. Manni. I was seeing how beautifully you are giving the instructions and giving all the clear messages to them. And I'm very fond of Kamal. He used to be my student. So that is the other thing which I wanted to add. And God bless all, and we all stay healthy and happy. And best wishes to the students. And tomorrow again, we will have the final show. Thank you very much. All the best.
Okay, thank you everyone. And I think now we can start with the actual quiz. I'll hand over to Dr. Kamal to conduct the quiz and give the rules first. Dr. Kamal.
Thank you so much, sir. And thank you, madam. It's because of the blessings of all my teachers that whatever I am today, I am here. So we will first begin with the rules, but I will request anybody who is there as a team to please put on their mask. The times are not right. So if you're alone, it doesn't matter. But if you're as a part of a team, then please put your masks on. So we'll first begin with the rules. We have 8 teams participating. We have numbered them from 1 to 8, and each team has 2 members, we know. And each team has to log in from the same computer. We have a digital supervisor who will ensure fairness. Now, we will have 2 rounds. It will be in a rapid fire mode. We will start from team A to team 8 initially, and then the second round will start from team A 8 back to team 1. And in each and every round, every team will be asked questions for 1 minute in a rapid fire mode. The answers will be in the true or false format. I would suggest please do not waste time. And since there is no negative marking, give an answer and move on. The faster you answer, the more questions you will get to answer. Secondly, we will not give you answers in the when the quiz is going on. It's only in the end of the quiz we'll tell you the scores and we will discuss the answers. So please, in case of a tie, we have a set of questions ready for you. So in case there is, we will handle that. Other than that, please keep your videos on at all times, and best of luck to all of you.
Please be on mute unless and until told to unmute, please.
So, as we have decided, first set of question is going to come to team 1. Team 1 is GMC Patiala. So, we will give you 1 minute for this. So, the time starts now. Patients with asthma and COVID-19 should continue to take their prescribed asthma medications, particularly inhaled corticosteroids with oral corticosteroids if prescribed. Please speak loud and clear. True. Okay. Written home asthma action plan given for asthmatic children, apart from other instructions, also include a short course of oral steroids. Yes. True. During COVID-19 pandemic.
True.
Yes, I'm just repeating your answer. I'm not giving you the correct answer. During COVID-19 pandemic, where possible, avoid use of nebulizers due to the risk of transmitting infections to other patients and to healthcare workers, and instead use MDI with spacer. True. Spirometry is investigation of choice in patients with asthma and confirmed or suspected COVID-19.
False.
Chronic wet cough suggests a diagnosis of asthma.
False.
Variable expiratory airflow limitation, diagnostic criteria for asthma, can be documented by spirometry. True. Positive exercise challenge test in asthma in children shows fall in peak expiratory flow by 10% after exercise.
False.
A normal physical examination in a child rules out asthma.
False.
The presence of a positive skin test or a positive IgE always means that the concerned allergen is causing symptoms, and avoidance will lead to clinical improvement.
True.
True. FeNO has an established role in ruling in or ruling out a diagnosis of asthma.
What? Question, repeat question.
Time is up. So please listen carefully. I think you have answered well. You did well. We will see the scores only at the end of the quiz, but I think you have attempted well. I would request all the participants to please be quick and don't waste time. There is no negative marking. So now I will move on to team 2, which is PGI Chandigarh. The time starts now. Reliever or rescue medications provided as needed relief of breakthrough symptoms and also used to reduce airway inflammation.
False.
8-year-old child prescribed low-dose inhaled corticosteroids is on 200 microgram budesonide twice daily by DPI.
False.
Preferred step 1 controller for adolescents with confirmed asthma is low-dose combination of inhaled corticosteroids or formoterol taken as needed for relief of symptoms.
True.
Once good asthma control has been achieved and maintained for 6 months and lung function has reached a plateau, treatment can often be successfully reduced without loss of asthma control.
True.
In a 3-year-old child with recurrent wheezing, therapeutic trial with low-dose inhaled corticosteroids and as-needed SABA, clinical improvement during 2 to 3 months of controller treatment and worsening when treatment is stopped is suggestive of asthma.
True.
Mepolizumab is biological agent has been approved for children aged 12 years and older with severe eosinophilic asthma.
False.
Alerts have been added about the risk of severe mental health adverse effects with montelukast, including the requirement by FDA for a boxed warning.
True.
New evidence suggests that 20% of the global asthma incidence in children may be attributable to traffic-related air pollution.
True.
Bronchial provocative testing by inhaled methacholine is a good test to assess bronchodilator reversibility.
False.
A 9-year-old child on low-dose inhaled corticosteroids and LABA is having uncontrolled symptoms. Pyrometry was done prior to starting treatment. Treating doctor plans pyrometry. Inhaled corticosteroids and LABA should be stopped 12 hours before test. I didn't get the answer.
Is it all?
Time is up. I can only take your answer, whatever you have given. It's not audible. Hello?
Hello, sir. I told true.
Achha, you said true. Fine. Time's up. I think you have also done well. So we have team 2, that is PGI Chandigarh. Maybe we can clap for them. They have done well. And now let's move on to the next team, team 3, which is GMC Faridkot. So all set?
Yes, sir. Yes, sir.
Fine. The first question. The long-term goals of asthma management are only to achieve good control of symptoms and maintain normal activity levels.
True.
No, she said false. Please, true and
True,
false.
true. I said true, sir.
True. Good
Yes.
communication. Good communication by healthcare providers is essential as the basis for good outcome in a child with newly diagnosed asthma.
True, true.
Early initiation of low-dose inhaled corticosteroids in patients with asthma leads to a greater improvement in lung function than if the symptoms have been present for more than 2 to 4 years.
True.
A 7-year-old child has troublesome asthma symptoms most days and waking up due to asthma twice a week. Ideal starting controller therapy for this child would be low-dose inhaled corticosteroids.
True.
A 10-year-old child presented for the first time with severe asthma-like symptoms and needed ICU care and ventilation. He has a strong family history of asthma. On discharge, child would be prescribed medium dose inhaled corticosteroids as a controller therapy with short course of oral corticosteroids.
True. True.
A 13-year-old child with asthma is detected to have sensitivity to house dust mite on skin prick testing. He is well controlled on low-dose inhaled corticosteroids. Allergen immunotherapy for house dust mite is indicated to improve asthma outcome.
False.
8-year-old child with asthma is uncontrolled on medium-dose inhaled corticosteroids and LABA. Adding tiotropium is an option in this child.
True.
A 14-year-old child has been prescribed high-dose inhaled corticosteroids and is taking budesonide 400 microgram morning and 800 microgram at bedtime by DPI.
True.
Omalizumab is indicated for children about 12 years with moderate or severe uncontrolled allergic asthma on step 4 and 5.
True.
Add on anti-interleukin 4R alpha treatment which is dupilumab, is indicated for patients more than 12 years with severe type 2 asthma.
No, false. False.
Thank you, team GMC Faridkot. We're finished with your time slotted. So I think our scorer is also trying to catch up with all you intelligent people because you are too fast for us. So so now that we will start with team 4, and team 4 is GMCH 32. Is it okay, GMCH 32?
Yes, sir.
Okay. In an obese child with asthma, inhaled corticosteroids and regular exercise is the mainstay of treatment.
True.
Patients with uncontrolled asthma must be screened for GERD.
True.
For patients with asthma and symptoms suggestive of reflux, an empirical treatment of anti-reflux medications such as proton pump inhibitors or motility agents may be considered.
True.
In children with confirmed food allergy, it is important to assess for asthma as they have a 4-fold increased likelihood of having asthma compared with children without food allergy.
True.
In adolescent girls with catamenial asthma, in addition to the usual strategies for management of asthma, oral contraceptives and or leukotriene receptor antagonist may be helpful.
False.
Patients taking long-term high-dose inhaled corticosteroids or who have received oral corticosteroids for more than 2 weeks during the previous 6 months should receive IV dexamethasone perioperatively as they are at risk of adrenal crisis in context of surgery.
True.
Allergic bronchopulmonary aspergillosis or ABPA is most commonly found in asthma due to hypersensitivity response to Aspergillus flavus.
True.
Correct first line therapy for ABPA is oral corticosteroids with itraconazole.
True.
Difficult to treat asthma is asthma that is uncontrolled despite GINA step 3 or 4.
True.
Type 2 inflammatory phenotype in a child with severe asthma is often characterized by eosinophilia or increased FeNO and may be accompanied by atopy.
True.
Time is up. Very good effort by GMC 32. Now we will move on to team 5, and team 5 is DMC Ludhiana. Please unmute yourself.
Unmuted, sir.
Okay. Am I audible?
Yes, sir.
Okay. So in low resource settings, variable airflow limitation can be confirmed using peak expiratory flow meters before start of long-term treatment.
Yes. True.
In assessment of asthma control, symptom control is the only domain under which child is assessed.
False.
High SABA use is not a risk factor for a poor outcome in a child with asthma.
True.
Persistent bronchodilator reversibility on follow-up spirometry in a child on long-term inhaled corticosteroids indicates uncontrolled asthma.
False.
With regular inhaled corticosteroids treatment, FEV1 starts to improve within weeks and reaches a plateau after around 6 months.
False.
Short-term and long-term peak expiratory flow monitoring is a useful tool in asthma management.
True.
Asthma severity is assessed retrospectively from the level of treatment required to control symptoms and exacerbations.
True.
Moderate asthma is asthma that is well controlled on step 3. We will take it as true. Inhaled SABA is treatment of choice in an adolescent with confirmed asthma and infrequent episodes.
False.
For children with confirmed asthma, diagnosis with persistent symptoms and or exacerbations despite low dose inhaled corticosteroids, immediate step up of steroid dose is an ideal option.
False.
In a child with asthma, considered step down once good asthma control has been achieved and maintained for about 6 months.
True.
Thank you, DMC Ludhiana, for your efforts. Thank you. Now we will move on to team 6, which is GMC Amritsar. Please unmute yourself. Am I audible?
Yes, sir. Are we audible?
Yes, keep yourself unmuted. Now we will start with your set of questions. A 6-year-old child is well controlled on low-dose inhaled corticosteroids. After 3 months, doctors decide to step down inhaled corticosteroids dose by decreasing daily dose by 25 to 50%.
True.
Asthma is a differential diagnosis. Asthma is a differential diagnosis in a 4-year-old child with cough and inspiratory wheeze since 1 month.
True.
A 7-year-old child had undergone spirometry on a follow-up visit. The report showed FEV1 less than 60% predicted and high bronchodilator reversibility. He is at high risk for asthma exacerbation. Please be quick.
True.
One more severe exacerbation in the last 12 months is not an independent risk factor for asthma flare-up in a child with asthma.
False.
Nasal itching, sneezing, and cough are a classical triad of symptoms of allergic rhinitis.
True.
Independent risk factors that have been identified for persistent airflow limitations include exposure to cigarette smoke.
True.
A normal or near normal FEV1 in a patient with frequent respiratory symptoms prompts consideration of alternative causes for the symptoms.
False.
Many children with uncontrolled asthma can have normal lung function between flare-ups.
True.
Excessive variation in peak expiratory flow suggests suboptimal asthma control and increased risk for exacerbation.
True.
A child well controlled on high-dose inhaled corticosteroids and LABA comes under the category of moderate asthma.
False.
Thank you, Team GMCH Amritsar, for your response. And I will request the participants to answer in one voice. And I will take up the first answer that you give. After that, whatever you may say will not matter. So please, even if you say thrice or 4 times, the first answer will be taken as the answer. You are a team, only one word should come from a team. Now, we will move on to team 7. And team 7 is CMC Ludhiana. Am I audible?
Dr. Kamal, your voice is echoing.
Is it fine, ma'am, now?
It is okay. It's okay now.
The echo is coming from their side.
Ma'am, on that side, I think from the CMC Ludhiana, there is a echo. There are 2 speakers which are going on, I believe.
Please log in from one account only. Both team partners should log in from one phone so that there is no echo. Please log out from the other device.
Yes, ma'am. Done, ma'am.
Yes, I think now it's clear. So, ready? Yes.
Yes, sir.
And please answer in true and false and only one answer. An occasional short-term increase in maintenance. An occasional short-term increase in maintenance inhaled corticosteroids dose for 1 to 2 weeks may be necessary during viral infections or seasonal allergen exposure, and this may be initiated by the patients according to their written asthma action plan.
True.
A 14-year-old child with asthma is well controlled for 3 months on high-dose inhaled corticosteroids and LABA maintenance treatment. Treating doctor plans to step down. Decreasing the dose of LABA by 50% is an appropriate action.
False.
A 6-year-old child with asthma is well controlled on low-dose inhaled corticosteroids for 3 months. Switching to as and when needed SABA with inhaled corticosteroids is a correct step down strategy.
True.
Routine pneumococcal vaccination in children with asthma improves outcome.
True.
Advise patients with moderate to severe asthma to receive an influenza vaccine every year.
True.
For confirmed food allergy, food allergen avoidance may reduce exacerbations.
False.
Correct advice about prevention and management of exercise-induced bronchoconstriction in a child with asthma is to start daily treatment with montelukast.
False.
Aspirin and beta blockers can make asthma worse and may precipitate an acute flare-up.
True.
And as asthma can be more difficult to control in obese patients, the risk of exacerbation is greater and response to inhaled corticosteroids may be reduced.
True.
There is strong evidence to support role of dietary substances, including benzoate, the yellow dye, tartrazine, and monosodium glutamate in worsening asthma.
True.
Thank you, team CMC Ludhiana, for the effort. And now we move on to team 8. And team 8 is SGRD Amritsar. Team 8, am I audible?
Yes, sir, you are audible.
Thank you. So we'll start. Non-type 2 inflammatory phenotypes is often characterized by increased mast cells.
False.
Overuse of SABA, especially use of more than 3 canisters of salbutamol monthly, increases the risk of asthma-related deaths.
True.
For children, please be quick. For children 6 to 11 years, the recommended dose of oral corticosteroids for home asthma action plan is 1 to 2 mg per kg per day to a maximum of 40 mg per day, usually for 3 to 5 days.
True.
A 8-year-old child, known case of asthma, arrives in ER drowsy, silent chest, rapid breathing. After assessment, he is labeled as severe attack of asthma.
True.
In children, oxygen saturation less than 95% is a predictor of the need for hospitalization.
True.
In a child presenting with severe respiratory distress, PaO2 less than 60 and CO2 and an increase in CO2 indicates respiratory failure.
True.
Target saturation while managing asthma flare-up is 93 to 95 for children 6 to 11 years.
True.
IV beta-2 agonists and adrenaline are drugs of choice in managing acute flare-up of asthma in pediatric ICU.
False.
There is sufficient evidence to recommend probiotics for the prevention of allergic diseases.
False.
Maternal dietary intake of fish or long-chained polyunsaturated fatty acids during pregnancy shows consistent improvement on the risk of wheeze, asthma, or atopy in the child.
True.
Thank you, team SGRD Amritsar. I think we have reached the midpoint of the journey. From there onwards, we will again begin with team SGRD Amritsar if they are not tired out. Before that, I will just catch up with my scorer whether we are up to date in terms of scoring or no.
Okay, while we are waiting and giving a breathing time for the teams, I just want to make a point here that I hope that all the students are appreciating the fact that this kind of quiz is going to add to their knowledge and to their expertise. It will also stimulate them to read further and to be in touch, because sometimes you take things for granted, you make a very superficial kind of study, but here you find that there are very specific questions, very specific situations. The answers are absolutely point on. And so the more you spend time on studying these, the more you will learn and the better treatment you will be able to provide to your patients. So a quick word from Dr. Rawat at this stage before we go on to the second round.
Yes, sir. I'd like to congratulate all the team that the way you are conducting the quiz, it is absolutely exemplary and everything is going absolutely smooth. And I think students and viewers must be enjoying it greatly. So my hats off to all of you. You are doing a great job, and it will be a great learning experience to all the students. As Dr. Daljit Singh is telling, that all the questions are planned in the way to stimulate you to think how you are going to act actually in your clinical practice. So don't worry whether you are attempted right or wrongly. You will get the correct answer at the end of the quiz, and definitely it will help you, stimulate you to study more and get a grip on asthma. Best of luck. Thank you very much. Excellent organization.
Thank you. Dr. Kamal, if you are ready, shall we start again for the second round?
Yes. Yes.
I think, sir, give us 2 more minutes. We'll finish the scoring of this round. And then
Okay,
we can start the second round.
Dr. Manmeet, I think you can also give a comment for how things are going and any advice to the students.
Actually, I have been a quizzer all my life, so it's actually, very unnerving to be on the other side. I actually want to participate. So I just feel like that, but they're all doing very good. The only thing is that don't waste your time thinking about it. It is very easy to say true or false because you get the next question then. So you don't waste your time. So you should complete all the 10 questions that you get. And I think we will be having a hard time getting the scores ready and finding just 4 teams. All of you are very good, I suppose. So all the best for the final, 10 questions, the final rapid fire that Dr. Kamal is going to do. And Dr. Kamal, you have been an excellent quiz conductor. That's very true.
Yeah. Yeah, congratulations, Dr. Kamal. You're doing a marvelous job. Voice is nice and clear and at the right speed so that the students don't get confused. It's very clear. I just want to add for the students that the tiebreaker will operate only if there is a problem about the fourth team, because 4 teams have to go into the next round, the final round. If there's a tie in the first or second, third teams, it doesn't matter because both of them, all of them will go into the next round. It's only if the fourth team ties with the fifth and sixth or only the fifth team, there will be a tiebreaker. So we have some questions ready for that, but let's see, maybe we won't need a tiebreaker and let's see how it goes. Kamal, I think now you probably should be ready to start off again.
Absolutely, sir. I think we have scored for the first round. And now I think team SGRD, Amrit sir, should be fighting fit. So, team 8, round 2. In an obese child with asthma, inhaled corticosteroids and regular exercise is the mainstay of treatment.
True.
Patients with uncontrolled asthma must be screened for GERD.
True.
For patients with asthma and symptoms suggestive of reflux, an empirical trial of anti-reflux medications such as proton pump inhibitors or motility agents may be considered.
True.
In children with confirmed food allergy, it is important to assess for asthma as they have 4-fold increased likelihood of having asthma compared with children without food allergy.
True.
In adolescents, girls with catamenial asthma, in addition to the usual strategies for the management of asthma, oral contraceptives and or leukotriene receptor antagonists may be helpful.
False.
Patients taking long-term high-dose inhaled corticosteroids or who have received oral corticosteroids for more than 2 weeks during the previous 6 months should receive IV dexamethasone perioperatively as they are at risk for adrenal crisis in context of a surgery.
False.
Allergic bronchopulmonary aspergillosis, that is ABPA, is most commonly found in asthma due to hypersensitivity response to Aspergillus flavus.
False.
Current first-line therapy of ABPA is with oral corticosteroids and itraconazole.
True.
Difficult to treat asthma is asthma that is uncontrolled despite GINA step 3 and 4.
True.
Type 2 inflammatory phenotype in a child with severe asthma is often characterized by eosinophilia or increased pheno and may be accompanied by atopy.
True.
Thank you, team SGRD Amritsar. Now I'll move on to team 7. Am I audible? Team 7, CMC
Yes,
Ludhiana.
sir.
Am I audible?
Yes, sir. Yes, sir.
The long-term goal of asthma management are only to achieve good control of symptoms and maintain normal activity levels.
True.
Good communication by healthcare providers is essential as the basis for good outcomes in a child with newly diagnosed as asthma.
True.
Early initiation of low-dose inhaled corticosteroids in patients with asthma leads to a greater improvement in lung function than if symptoms have been present for more than 2 to 4 years.
True.
A 7-year-old child has troublesome asthma symptoms most days and waking up due to asthma twice a week. Ideal starting controller therapy for this child would be a low-dose inhaled corticosteroid.
False.
A 10-year-old child presented for the first time with severe asthma-like symptoms and needed pediatric ICU care and ventilation. He has a strong family history of asthma. On discharge, child should be prescribed medium-dose inhaled corticosteroids as controller with a short course of oral corticosteroids.
True.
A 13-year-old child with asthma is detected to have sensitivity to house dust mite on skin prick test. He is well controlled on low-dose inhaled corticosteroids. Allergen immunotherapy for house dust mite is indicated to improve asthma outcome.
False.
8-year-old child with asthma is uncontrolled on medium-dose inhaled corticosteroids and LABA. Adding tiotropium is an option in this child.
True.
A 14-year-old child has been prescribed high-dose inhaled corticosteroids and is taking budesonide 400 microgram morning and 800 microgram at bedtime by DPI.
True.
Omalizumab is indicated for children about 12 years with moderate to severe uncontrolled allergic asthma on step 4-5.
False.
Time is up, team 7. This one is marked as false. Thank you. I will again request all the teams not to waste time too long on one question. Move on so that you get to answer one more question. So the next team now is team 6, which is GMC Amritsar. Is it audible?
Yes.
Thank you. Reliever medications provided as needed relief for breakthrough symptoms and also used to reduce airway inflammation.
True.
8-year-old child prescribed low-dose inhaled corticosteroids is on 200 microgram budesonide twice daily by DPI.
False.
Preferred step 1 controller for adolescents with confirmed asthma is low-dose combination inhaled corticosteroids, formoterol, taken as needed for relief of symptoms.
False.
Good asthma control has been achieved and maintained for 6 months, and lung function has reached a plateau. Treatment can often be successfully reduced without loss of asthma control.
True.
In a 3-year-old child with recurrent wheezing, therapeutic trial with low-dose inhaled corticosteroids and as-needed SABA, clinical improvement during 2 to 3 months of controller treatment and worsening when the treatment is stopped is suggestive of asthma.
True.
Mepolizumab is biological agent approved for children aged 12 years and older with severe eosinophilic asthma. True?
True.
Alerts have been added about the risk of severe mental health with montelukast, including a requirement by FDA for a boxed warning.
True.
No evidence suggests that 20% of new evidence suggests that 20% of global asthma incidents in children may be attributable to traffic-related air pollution.
True.
Bronchial provocation testing by inhaled methacholine is a good test to assess bronchodilator reversibility.
False.
A 9-year-old child on low dose inhaled corticosteroids plus LABA is having uncontrolled symptoms. Spirometry was not done prior to starting treatment. Treatment doctor plans spirometry. Inhaled corticosteroids and LABA should be stopped 12 hours before test.
True.
Thank you, Team 6, GMC Amritsar, for the effort. Thank you so much. So the next team in the hot seat now is Team 5, which is DMC Ludhiana. DMC Ludhiana, am I audible?
Yes, sir.
Thank you so much. So patients with asthma and COVID-19 should continue to take their prescribed asthma medications, particularly inhaled corticosteroids and oral corticosteroids if they have been prescribed.
True.
A written home asthma action plan given for asthmatic children, apart from other instruction, also includes a short course of oral steroids.
True.
During COVID-19 pandemic, where possible, avoid use of nebulizers due to the risk of transmitting infections to other patients and to healthcare workers, and instead use MDI with spacers.
True.
Spirometry is investigation of choice in patients with asthma and confirmed suspected COVID-19.
True.
Chronic wet cough suggests a diagnosis of asthma.
False.
Variable expiratory airflow limitation, diagnostic criteria for asthma, can be documented by spirometry.
True.
Positive exercise challenge test in asthma in children shows fall in peak expiratory flow by 10% after exercise.
True.
A normal physical examination in a child rules out asthma.
False.
The presence of a positive skin test or positive IgE always means that the concerned allergen is causing symptoms and avoidance would lead to clinical improvement.
True.
FeNO has an established role in ruling in or ruling out a diagnosis of asthma.
True.
Thank you, Team 5, DMC Ludhiana, for the effort. Thank you so much. So the next team in the hot seat now is Team 4, which is GMCH 32. Am I audible?
Yes, sir.
How's the Josh?
Yes.
The yes was not so good. So the HOD is there.
Yes, sir.
So just to make things in a lighter vein, so we will start with Team 4. Non-type 2 inflammatory phenotypes is often characterized by increased mast cells.
True.
Overuse of SABA, especially use of more than 3 canisters of salbutamol per month, increases the risk of asthma-related deaths.
True.
For children 6 to 11 years, the recommended dose of oral corticosteroids for asthma home action plan is 1 to 2 mg per kg per day to a maximum of 40 mg per day, usually for 3 to 5 days.
True.
A 8-year-old child, known case of asthma, arrives in ER as drowsy with a silent chest and rapid breathing. After assessment, attending doctor labels it as severe attack of asthma.
True.
In children, oxygen saturation less than 95% is a predictor of the need for hospitalization.
True.
In a child presenting with severe respiratory distress, a PaO2 of less than 60 millimeters of mercury and normal to increased PaCO2 indicates respiratory failure.
True.
Target saturation while managing asthma flare-up is 93 to 95% for children 6 to 11 years.
True.
IV beta-2 agonist and adrenaline are drugs of choice in managing acute flare-ups of asthma in pediatric ICU.
True.
There is sufficient evidence to recommend probiotics for the prevention of allergic diseases.
False.
Maternal dietary intake of fish, a long-chained polyunsaturated fatty acids, PUFA, during pregnancy showed consistent effects on the risk of wheeze, asthma, or atopy in the child.
False.
Thank you so much, team GMCH 32, for the effort. Thank you very much. And now we move on to team 3, which is GMC Faridkot.
Yes, sir. Yes, sir.
Am I audible?
Yes, sir. Yes.
Thank you. An occasional short-term increase in maintenance inhaled corticosteroids for 1 to 2 weeks may be necessary during viral infections or seasonal allergen exposure. This may be initiated by the patients according to their written asthma action plan.
True.
A 14-year-old child with asthma is well controlled for 3 months on high-dose inhaled corticosteroids and LABA. Treating doctor plans to step down. Decreasing the dose of LABA by 50% is an appropriate step.
False.
A 6-year-old child with asthma is well controlled on low-dose inhaled corticosteroids for 3 months. Switching to as and when needed SABA with inhaled corticosteroids is a correct step-down strategy.
True.
Routine pneumococcal vaccination in children with asthma improves outcome.
True.
Advise patients with moderate to severe asthma to receive an influenza vaccination every year.
True.
For confirmed food allergy, food allergen avoidance may reduce asthma exacerbations.
True.
Correct advice about prevention and management of exercise-induced bronchoconstriction in a child with asthma is to start daily treatment with montelukast.
False.
Aspirin and beta blockers can make asthma worse and may precipitate an acute flare-up.
True.
Asthma can be more difficult to control in obese patients. The risk of exacerbation is greater and response to inhaled corticosteroids may be reduced.
True.
There is strong evidence to support role of dietary substances, including benzoate, yellow dye, tartrazine, and monosodium glutamate to worsen asthma.
False.
Thank you, team 3, GMC Faridkot, for the effort. Thank you very much.
Thank you.
So we are nearing the very end of our quiz, and we have 2 teams left for the final second round. The next team is Team PGI Chandigarh.
Yes, sir.
Am I audible?
Yes, sir.
A 6-year-old child is well controlled on low-dose inhaled corticosteroids. After 3 months, doctors decides to step down inhaled corticosteroids by decreasing daily dose by 25 to 50%.
True.
Asthma is a differential diagnosis in a 4-year-old child with cough and inspiratory wheeze since 1 month.
False.
A 7-year-old child had undergone spirometry on a follow-up visit. The report showed FEV1 less than 60% of predicted with a high bronchodilator reversibility. He is at high risk for exacerbation.
True.
1 or more severe exacerbation in the last 12 months is not an independent risk factor for
False.
asthma flare-up in a child with asthma. Nasal
False.
itching, sneezing, or cough are a classical triad of symptoms of allergic rhinitis.
True.
Independent risk factors that have been identified for persistent airflow limitation include exposure to cigarette smoke.
True.
A normal or near normal FEV1 in a patient with frequent respiratory symptoms prompts consideration of alternative cause for the symptoms.
True.
Many children with uncontrolled asthma can have normal lung function between flare-ups.
True.
Excessive variability in peak expiratory flow suggests suboptimal asthma control and increases the risk of exacerbation.
True.
A child well controlled on high-dose inhaled corticosteroids plus LABA comes under the category of moderate asthma.
Sir, can you repeat the question?
It has been marked as true. Thank you. Thank you, PGI Chandigarh team, for the effort. Thank you. And so we are with the last team that we have for this quiz, team 1, GMC Patiala. Am I audible?
Yes, sir.
Thank you. In low resource settings, variable in airflow limitation can be confirmed using peak expiratory flow meters before start of long-term treatment.
True.
In assessment of asthma control, symptom control is only domain under which child is to be assessed.
False.
High SABA use is not a risk factor for a poor outcome in a child with asthma.
False.
Persistent bronchodilator reversibility on follow-up spirometry in a child on long-term inhaled corticosteroids suggests uncontrolled asthma.
True.
With regular inhaled corticosteroids treatment, FEV1 starts to improve within weeks and reaches a plateau after around 6 months.
False.
Short-term and long-term peak expiratory flow monitoring is a useful tool in asthma management.
True.
Asthma severity is assessed retrospectively from the level of treatment required to the control of symptoms and exacerbation. Moderate asthma is asthma that is well controlled on step 3.
True.
Inhaled SABA is treatment of choice in an adolescent with confirmed asthma and infrequent episodes.
False.
For children with confirmed asthma diagnosis with persistent symptoms and or exacerbations, despite low dose inhaled corticosteroids, immediate step up of steroid dose is an ideal option.
True.
In a child with asthma, consider step down once good asthma control has been achieved and maintained for 6 months.
True.
Thank you, team GMCA Patiala, for the effort. Thank you very much. So we have finished the round of questions from all the teams. Now it is up to Dr. Aljeet Singh and ma'am.
Yes, I think this was a wonderful contest. So interesting to see the variety of questions and the answers, which were very nicely. I must say, I'm impressed by the speed and the alertness of these students, because we oldies will take our time to think about what the question was in the first place. Before we go to the scores, I think we need to do two things. One is I'll request some of our senior teachers and colleagues here to say a few words. I think Dr. Meenu Singh is here, Dr. Puneet, and any other, because I can't see on the screen here. So can you just give a little comment?
Thank you, Dr. Daljeet Singh, for having this event today. It's actually the questions are so good that the answers to these really require exercising one's mind, and they are really not based on memory. So I think this type of quizzes is something which really gives a very good learning experience to the participants. I think all the teams are doing very well, and we really don't know what the result will be, but all of them have, I think, answered more than 80% correct. So let us see what the results are going to be. But I think it's a very good learning exercise. It really doesn't let the learners sleep during the proceedings. So we should have more of these, I think. Thank you, sir, for organizing this.
Thank you, Dr. Meenu, and it was so nice of you to graciously accept for having this quiz conducted, because you have the infrastructure there and the scorer and Dr. Kamal doing
Yes,
a
of
marvelous
course,
job.
Dr. Kamal is with us these days.
Yes.
So he is actually a well-established quiz master in Delhi.
Yes.
So he's right now doing his DM with us. So
Right. Thank
he's
you, ma'am.
there. So that way we were quite at
A word
advantage.
from
Thank you so
Dr.
much.
So thank you, ma'am. A word from Dr. Randhawa and Dr. Puneet, if they're there, and any other senior who's around.
Good afternoon, everybody. I must congratulate all the teams. They have boosted our morale. We were very apprehensive to start with that, how to go about it. Doing quiz on a virtual platform, it was a big challenge for all of us. All not very that tech savvy. But thank you, all the students. My blessings and good wishes you for your great future and excellent career. And I thank all of you for nice and enthusiastic participation.
Dr. Puneet, are you there? And Dr. Gursharan and any other teacher? I'm not sure who all are there. I think from Chandigarh, yeah, Dr. Guliani, yeah.
Myself, Dr. Vishal Guglani.
Yeah, Guglani, sir.
And I will just like to give a comment that it was very well conducted, and most of the participants have participated and in a very good manner, and they have tried their best. And I would like to say that Dr. Kamal has done a wonderful job, and he's always a star performer in all the events. which I have attended. And I'm a great, I always appreciate his presentations.
Thank you.
Thank you.
Thank you. If there's no one else, then I would just request Dr. Kamal that he may have picked up some of the questions which people were not able to answer nicely, and leave the others because there are too many questions to discuss. But if there are some common errors or common things which he noted were being answered wrongly, he can just clarify those kind of questions.
Thank you so much, sir. And thank you everybody for the nice words that we have. First of all, I think we have 8 winners over here. The 8 teams who have participated. So a round of applause for the 8 teams who have participated. It's their participation that has led to all this. Someone can go up, someone can go down, but I think all of you have won over here in this event. Thank you so much. And now we are in for a surprise. And as very closely we have avoided a tie somehow. It was almost going to be a tie, but the top 2 teams have equal marks and 3 or 4 has equal marks. So it's just that the 4th and 5th do not have it. So we are out of that tie. Otherwise, we are going to go into that. Now, coming back to the questions that have been put up and some which they have not been answered. I think there has been a change in 2019 GINA guidelines. Prior to that, the first thing that you would do in asthma is that if it is intermittent, if it is not that one, we will give only SOS, short-acting beta-T agonist. And that had been a practice for very long. That if the child is not having persistent symptoms and the symptoms are only intermittent, you give short-acting beta-2 agonist whenever they need it, SOS. What happened in 2019 is this thing changed. And even when you are using a drug as SOS, it is to be a combination of steroids and a LABA. And that is a change that has happened. So many questions were based on that. There are reasons for that, because one, as you would know in many of these questions, SABA doesn't control inflammation. And sometimes because it gives an acute relief, a patient believes that this is the drug that I need, rest is all not useful. They continue to use SABA, overuse SABA, and the underlying inflammation goes on. And that sets a stage where the patient will come to an emergency with an exacerbation. And because the inflammation underlying has not been controlled. So there are many reasons for that, but that has been one change which is very obvious. Now we will quickly go through the wrong answers, and if I can find out something which looks conspicuous, I will try to answer that. Chronic wet cough suggests asthma? Never. It is usually a dry cough which suggests asthma. You can have a reactive airway as a comorbidity in many conditions, right from cystic fibrosis to many other conditions. But to label it as purely asthma, no. Asthma usually is a dry cough and not a wet cough. When you have a wet cough, think of a chronic suppurative lung disease, where a reactive airway can be a comorbidity, but that alone cannot explain. Now, there is a question that the presence of a positive skin test, raised IgE, always means that the concerned allergen is causing symptoms, and avoidance would lead to clinical improvement. Now, what we need to understand that there are 3 things in this. One, that there has been an allergen to which a person is exposed. Once he is exposed, then there are chances that he will get sensitized. So that is another step. Third step is that that particular sensitization leads to a clinical disease. And then fourth step is that that disease is treatable by avoiding that allergen. Now, if you look at these 4 steps, the things are not so simple. There are so many slips between the cup and the lips. So it seems that if I'm exposed to an allergen, I get sensitized, I will have a clinically significant disease, and avoiding that allergen will lead to a clinical improvement. This chain doesn't fit in always. So sometimes those who are sensitized may not have a disease. Sometimes those who are not sensitized, these tests also have a problem. So the message here is that skin test, IgE test, they are not sacrosanct. It has to be seen in the light of the clinical picture of the patient. FeNO is an established role in ruling and ruling out diagnosis. FeNO is used for monitoring of asthma, but as a ruling and ruling out diagnosis, it is difficult. Yes, when you are, there is one question that a 9-year-old child on low dose inhaled corticosteroid and LABA has uncontrolled symptoms. Spirometry is to be done. So when spirometry is to be done and the patient is on LABA, it should be stopped for 24 hours at least. Otherwise, it will affect the spirometry investigation, because no, spirometry is about testing reactivity, then giving a short-acting beta-2 agonist, and then looking at the reversibility. If the patient is already on LABA, that the result may get truncated, and the number here is 12%. In one of the cases, that was 10%. So if there is a 10% change, you call it a significant reversibility. And if suppose it is technically 11 or 10, it is not significant reversibility. So if the person has taken LABA within 24 hours, then it can be because of the drugs that the significant reversibility is not picked up. So if it is about short-acting beta-2 agonist, maybe 12 hours. But when it is about long-acting beta-2 agonist, it has to be 24 hours at least. Again, the same with house dust mites. This exposure, sensitization, clinical disease, and resolution of symptom with removal of that. It's not always that the chain is complete. In obese children, regular exercise, children with asthma, inhaled corticosteroids and regular exercise is the mainstay of treatment. This is false, because along with the above two, weight reduction is an important criteria. For somebody who is obese, the asthma control will be better if the weight is controlled. Now, ABPA, there is a word that the first line treatment for ABPA is corticosteroids and itraconazole, and many of you have marked it incorrectly. ABPA is like somebody who is exposed to the fungus, which is Aspergillus fumigatus and not flavus. So the fungus is Aspergillus fumigatus. You can get exposed to that, you can get sensitized to that, and then you can have a reaction to that. That reaction is called allergic bronchopulmonary aspergillosis. The treatment is primarily steroids. It is only when the patient is not responding to adequate and appropriate dose of steroids that you will need to add itraconazole it will reduce the load of fungus and it will help. So that is another way of looking at it. So the primary treatment is corticosteroids and not a combination always. Combination is used only when one fails. So if there is any specific question anybody has from these questions, then maybe we can take it up. And we have all the experts here who can add on, differ from me. And then one target saturation while maintaining asthma flare-ups is not 93 to 95% for children 6 to 11 years. For children 6 to 11 years, it is 98%. And another one that we have, that if, as I said, if somebody is overusing SABA, he will have control symptoms, but even then he will be at risk of exacerbation because the underlying inflammation is going on. And the criteria for that is if he is using more than 1 canister per month, that means 12 canister per year, he is a patient who is at risk for asthma-related death. The third here was 3 canister of salbutamol monthly, but if it is above 1, it becomes a risk for exacerbation because of that. Thank you so much. And if anybody has any clarification regarding any of these questions, we have the experts with us. If you differ from the answer that has been given in this key,
very nicely explained, Kamal. I think there is one little tip which one could give to people who take part in quizzes in general. You know, when you're talking about true and false kind of answers, when you have a question which is absolute, for example, something is always, yeah, something is never, usually that rules out the true nature of that question. I mean, this is just in general as a tip, that 100% things are usually not there. And similarly, if a question says maybe something, then that is possibly more likely to be correct answer, because again, nothing is 0% and nothing is 100%. So that's a little tip. If you don't know the answer, sometimes you can even guess what the likely answer is going to be. Is there anyone else who would like to make a comment before we get to the stage of declaring the results? Dr. Gurdeep, are you there? Gurdeep Dhuria? He had raised his hand in this.
Am I audible?
Yeah, sure. Go ahead.
My question is, in under 5 Visa, the maximum dose, that is, there is no such dose as low dose. Only that is the only dose that is advisable. Is there a moderate or severe dose in under 5? That is the question, because the GINA guidelines gives only low dose steroid. So what is the clarification on that?
Should I take up this question?
The under 5 Visa, only the low dose is mentioned. There is no moderate or severe dose mentioned there in the GINA guidelines. So can we clarify on that?
Thank you so much, sir, for the question. Now, when we think about under 5 Visa, here the diagnosis of asthma is also a big if. So it's only under very strict conditions that we label an under 5 Visa as asthma. And we need to have a very strict set of criteria when we label somebody as under 5 Visa. And you are absolutely right. Usually when you start such children, otherwise also, if you look at the GINA guidelines and the present guidelines, this line between what is low dose, what is medium dose, which is high dose, it is not so sacrosanct and clear. And the tables that are given in GINA, the suggested doses are also in a way suggested doses. They will not absolutely say what is high and very high. But especially when we come down to under 5 Visa, making a diagnosis of asthma in itself is an issue. But if you have reasons to believe that the child has asthma, then at times you have to start a trial of steroids rather than to begin treating asthma as upfront. And in that, you will give a trial of this low dose budesonide for around 3 months. If there is a response, you stop it. If it comes up again and you start treatment, it stops. So this 3-step way has been recommended as one way of diagnosing asthma and then continuing treatment. So, but in under 5 Visa, most of the guidelines will not apply or will not hold true.
Correct. Thank you.
Thank you, sir.
Thank you, sir.
Great. I think it's time now to come down to the scores and the final results. And I'll request Dr. Palvinder Singh, who is the president of the College Academy of Pediatrics, to join us. And, let's hear the scores. And I'll request Dr. Palvinder to formally declare the on to the final to be held tomorrow.
Sir, should I give you the scores?
Yes, can you please?
Yes, sir. I will give you the scores. So the top scoring teams who are tied at the top are GMC Patiala and PGI Chandigarh. So these two teams are on the top with equal marks. Then the next two teams with equal marks, again tied together in the second spot, are GMC Faridkot and CMC Ludhiana. So the 4 teams that are going through to the next round are, I'll repeat again, GMC Patiala, PGI Chandigarh, GMC Faridkot, and CMC Ludhiana. And I would want to thank GMC CH Sector 32 team, DMC Ludhiana team, GMC Amritsar team, and SGRD Amritsar team for participating and making this event happen. Thank you so much.
Thank you, Dr. Palvinder. If you could formally declare the results, the teams which will go to the final round tomorrow.
Yeah.
I think as already told by sir that I think GMC Patiala and second is Vijay and third is hello.
Faridkot.
Yes, Medical College Faridkot, Guru Gobind Singh Medical Faridkot, and last one CMC, I think. Huh?
CMC Ludhiana.
So I once again congratulate all these 4 teams and wish them the best of luck for tomorrow's final quiz. And I also compliment all the teams because as Dr. Daljit Singh few days back already commented that no doubt it is a competition, but most likely it is a learning activity and it will not only help them in their final examination, but in their future also to take care of these patients in a much better way. Thank you. We will meet tomorrow.
Right.
Sir, I want to make a request that
Yes.
all the participating teams for the final, they must share one mail ID for logging in, because they will get the joining link, panelist link by the DIAP team. In our Asthma quiz group, they are all member of that part. And I request all the other teams who couldn't make it to the final event, you must watch and you must share this information with your residents across India and across the globe. That it is one of the best learning experience one can have. So that all should join the viewers link we will share in the Asthma quiz group. You can be part of this group for till tomorrow. And the others, all the dignitaries also to share their mail IDs to get the viewers link. And today evening, if DIAP team feels fit, they might give us a test run so that the participating team, because this event is going to be beamed across the nation and the other countries also, so that to have the best audio and video quality, if there is a test run around, it will be around 8 o'clock in the evening. That the information will be given in the same group. Thank you. Dr. Puneet is around. I think, Dr. Puneet, you want to make a comment?
Sorry, hello, hi, good afternoon. Sorry, I missed it initially because I was driving. I have a class 2 hours demo class with the UGs online. So I was just preparing that. I think it went very well and the questions were very well drafted. Good to have this type of stimulation for our students, because learning with fun is always better and you remember it for a long time. And it was so good to see Dr. Daljit Singh active in the quiz. Sir, carry on, ji. Sare department specialties mein we want quizzes like this.
Undergraduate भी रख लेने डॉक्टर साहब.
Thank you, respiratory chapter. I think we should have for all the specialties. It's a best way to learn, and you always remember, especially the questions which were wrong. Students always remember. Great learning exercise. Thank you so much. Keep it up.
Thank you.
Thank you. And before we wind up, the last word from Dr. Manmeet, who is basically coordinating all the activities here along with Dr. Randhawa. Manmeet.
Good afternoon, everyone. And I'm just so happy that final 4 teams who will, make us again, be on the nerves tomorrow. So I request everyone to keep your mind cool tonight and gear up for the session tomorrow. And as far as the conduction of the quiz, it was wonderful. And, it makes your brain, scratching, you keep your thinking, what is the next question? What is the next question? That is the, I should say, charisma of quizzing. So all the best to us for the next round. And don't be disheartened. Whoever has not won, they have learned lot many new questions of asthma. So that is your prize actually. You gain knowledge prize. So all the way to the teams, the finals. And thank you so much for all the participants to the quiz. Quiz conductor, Dr. Kamal Singhal, and scorer. Well done, everyone. Thank you so much. Till we meet again, keep quizzing.
Right. So we'll sign off here and see you all tomorrow evening for the final.